Hi, everybody. I'm Leslie Lake. Welcome to the National Blood Clot Alliance mini PEP, Patients Educating Patients. We have a really fantastic discussion here today. I'm joined by my fellow Pepper, Todd Robertson, who is my fellow board member and head of all things patient communications at NBCA. And we are very fortunate today to have Dr. Suresh Vedantham with us from Washington University in St. Louis. I'm going to give a brief introduction on his background. So Suresh, thank you very much for joining us today.
Thank you.
So Suresh is the professor of radiology and surgery at the Mallinckrodt Institute of Radiology at the Washington University School of Medicine in St. Louis. He is one of the world leaders in the interventional radiology space, and he specializes in the delivery and clinical investigation of image-guided therapies for venous thromboembolism, VTE. He has a very robust clinical practice in which he sees patients with complex vascular thrombotic disorders. Many of these patients are referred to him both locally, nationally, and of course internationally as well for treatment. And those treatments often include innovative image-guided procedures. Suresh has devoted his career to the development of high-quality evidence to guide venous patient care. He serves as the national principal investigator of the landmark multi-center NIH-sponsored CTRACT and CTRACT trials, which he's going to speak to us about today, which are really defining the appropriate role of catheter-based endovascular therapy in the management of DVT and its complications. And as patients, we know there are some very serious complications with DVT. Suresh at Washington U serves as the Assistant Dean for Clinical Research and is chairperson of the Institutional COVID-19 Clinical Studies Committee. He was honored to serve as the 2017-2018 president of the Society of Interventional Radiology. He has also been a long-term member of the National Blood Clot Alliance Medical and Scientific Advisory Board. And Suresh, we are so thrilled to have you here today to really lead this discussion. Todd and I are very informal, and so we are going to refer to you on a first name basis, if you're okay with that.
Absolutely.
Super. So that is your incredibly impressive resume. We're going to start first with, so you're an interventional radiologist. We've been spending a lot of time really talking to patients about who is on your healthcare team, what do they do. This is the first time we've ever had you on one of our PEPs. We would love for you to explain to all of us, what is an interventional radiologist, first of all? What role do you play in the patient's overall healthcare team, and how does that impact blood clot patients?
Sure. Well, first of all, thanks so much for having me, and it's really a pleasure to be here and talk to both of you and to your audience, really. And hopefully, this will spark some discussion, and I can contribute to people's best understanding. So, an interventional radiologist is a medical doctor who specializes in the delivery of minimally invasive treatments using imaging guidance. So we are trained initially as imagers, as radiologists, and then we specialize in our training in the delivery of imaging guided procedures. And the whole idea here is that there are many types of treatments that used to require open surgery, but by seeing inside the body so effectively now, using imaging, now we are able to deliver many of those treatments in a much more convenient and safe manner using minimally invasive technology.
I'm curious to know, so you've been at this for a while now, how it has evolved over time during your career.
Oh, it's evolved tremendously. You know, it used to be that interventional radiologists were what used to be called the physician's physician. In other words, we were sort of behind the scenes. And I think that other doctors that had access to an interventional radiologist would solve problems of certain kinds by referring patients. But generally speaking, I don't think most patients or laypersons really had any idea that we even existed. I think, though, that as the years have gone by, there are more diseases and conditions for which interventional radiologists can provide useful guidance and treatments. And so we have evolved towards becoming more knowledgeable and patient engaged practitioners. And of course, we can deliver our imaging guided procedures, but we also deliver other kinds of treatment, and we provide counseling to patients as well as patient evaluation. So I think that's the biggest trend in our field over the years.
That's fantastic. And that'll be something that continues to evolve over time. Great.
Absolutely.
Okay. Thank you. Todd?
Yeah. Hi, Suresh. Hey, I'm so glad you're here. And I want to talk to you. I want to ask you about PTS because I'm real lucky. I've had 5 DVTs, but I've never had to suffer what a lot of people suffer. And, I have recovery guilt for that. But a fair amount of patients experience post-thrombotic syndrome or PTS. Can you explain to our audience what that is?
Sure. So about half of patients that have a blood clot of the leg will eventually develop something called post-thrombotic syndrome, which, if you really take the words away, it's after clotting syndrome, right? And most commonly that is manifested by swelling, aching of the leg, fatigue of the leg, and that affects patients on a daily basis, months or years after their initial blood clot. Once that condition is there, it's very difficult to manage and treat, and it tends to be a long-term condition that the person has to deal with in their daily life on a daily basis. It varies tremendously from patient to patient. Some people have more swelling, some have more aching, some have less of both, but have progression of skin changes on their leg, and then a minority even develop open sores called ulcers on their leg. And so it's really kind of a multi-headed condition. And in terms of what causes it, we have some information, but we don't know the whole story, unfortunately. What we do know is that part of the story is that patients have, when you had your blood clot, you received blood thinning drugs, and those are very effective in preventing new clots, and they're very effective in preventing clots from breaking off and going to your lungs. But for the blood clots that have already formed, they don't really actively remove them. And it's really up to each person's body to try and remove as much clot as possible. And it just turns out that patients vary tremendously in their ability to do that. Smaller clots are more likely to be completely removed by the body. Larger clots, much less so. And so many patients have, even with good treatment with blood thinners, they have substantial amounts of residual blood clot still remaining in their veins, causing partial or complete blockage of those veins. The second thing that happens is that when you have a blood clot, the body reacts to that in order to defend the patient. But in the course of that, the process of reaction, we call in a very generic way inflammation. But what that process can do is it can cause further damage to the vein and the vein valves. Inside your veins are one-way valves, so that when you're standing up, blood and pressure are not transmitted to the bottom with gravity. But when those valves don't work properly, the extra pressure in the blood system is transmitted downwards. And that, combined with the partial blockage due to old blood clots, results in elevated pressures, you could say, in the venous system of the leg when patients are upright. And so that unfortunately leads to quite substantial difficulties. Some people have very mild symptoms where at the end of the workday, maybe they have to just elevate their leg and their swelling goes away. But then there are many other patients that have very substantial problems. They can't really even walk several blocks without massive swelling of their leg or aching. They feel like they're dragging their leg with them. And that can impact their quality of life, their ability to work, their ability to conduct daily activities quite significantly.
Very well explained. Thank you very much. Leslie?
Do you know what percentage of DVT patients get PTS? And I'm also curious to know, you mentioned that, people are different in terms of their ability to get rid of a blood clot. Do you know why that is?
So about 40% of patients who develop a blood clot of the leg will develop some level of post-thrombotic syndrome.
Wow.
In the people that have the larger blood clots that are at the knee or above, what we call proximal DVT, those patients, about half of them will develop post-thrombotic syndrome. In terms of why some patients seem to develop it and others don't, and why some patients can melt away their clot and others don't, some of it is likely in the genetics. Unfortunately, the genetics are complex, and we have tests for a few disorders, but quite honestly, there's a lot more there, And And it's not just the clot. There's one part of it is the ability to remove blood clot, but the other part of it is what is the body's reaction to the blood clot. And that also varies tremendously from patient to patient. And people who tend to have the worst symptoms up front tend to be more likely to develop post-thrombotic syndrome down the road, but unfortunately, the whole story isn't understood yet, and there's a lot of research to try and understand that.
Hey,
Yeah.
so, Suresh, I can hear some of the patients saying now, what can I do to relieve that pain? Is elevation and compression like the main two go-tos when it comes to trying to relieve some of that discomfort? Do you have anything to add there?
Yeah, so I think that those are definitely helpful, and in elevating the leg, and I think trying to build in. I think many people elevate their leg when it gets to be so intolerable they can't keep going. But if a person is able to build into their day periods of time when they can elevate their leg for 10, 15 minutes, I think that helps prevents things from building up later on in the day,
Okay.
And that prevents that discomfort from accumulating later on in the day.
Okay.
The other things, using compression stockings can be helpful in controlling, in particular, the swelling and the heaviness. Prescription stockings are best, and I know now there's such a wide variety of garments that you can get online now. And I think one thing that's very important is to realize that the prescription stockings, unfortunately, they have a cost that goes with them, but they are built to have more pressure in the area where there's the most pressure building up, at the lowest part of near the ankle, and that does help in terms of the ability to get blood out of the leg and to prevent swelling.
Good point. Thank you.
And does PTS only occur, are you focused only on the legs, or could it also actually occur in arms?
Can occur in arms as well, absolutely. It tends to be less common in the arms, mainly because one, the body is pretty good at developing collateral veins around a blocked vein, and then also the effective gravity isn't there to the same degree as someone that's
Sure.
walking. It's just not as important. But definitely there are patients that get post-thrombotic syndrome of the arm. There's also compression garments for the arm as well that can be helpful with that.
Yeah. Okay. All right. So given all the work that you've done in this space, and you really are one of the leaders in the PTS field, so you launched a trial recently called CTRACT. I think there was a predecessor to that. So what is this? What are the goals? And maybe you can incorporate, to our audience, what open vein theory is and how it all kind of flows together.
Sure. Well, so over the years, doctors have made the observation that in people who seem to have the worst symptoms and the worst post-thrombotic syndrome, they just tend to have a lot more in the way of their veins continuing to be blocked from old clot. And so over the years, a theory has developed that maybe if we were more aggressive about removing blood clots or about keeping veins open at least, then patients might be a lot less likely to develop these long-term problems, and the severity of those problems might be less. And there's lots of studies and observations that have indeed confirmed that notion that the less clot that's in the system down the road and the more open the veins are, the better the patient's going to feel. Now, saying that more open veins is better for health is not quite the same thing as saying that undergoing a procedure to open your veins, that it's necessarily going to be the right thing for you. That's going to vary from person to person quite a lot. And so right now we're doing a study that's called CTRACT, and it's focused on the observation that in people who have blockage of the largest vein that drains the leg. So again, the veins in the leg all kind of come together in the groin, and then they form one common vein that then flows back up on that side in the pelvis, and that's called the iliac vein. And when that vein is blocked, either completely or partially, people tend to get much more significant symptoms in their leg. And over many years, we've learned that we are able in many patients to open that vein up by placing what are called stents, which are basically metal mesh tubes that prop open that vein. And we've been doing that for many years in very highly selected patients. And we seem to have observed that many of them seem to be getting better afterwards in terms of having less swelling and aching. But then again, these are permanent devices that go in the body. We don't necessarily have really structured long-term follow-up to know what happens to them in the long run. And so as a result, we're currently doing a study called CTRACT that's really focused on determining, okay, if we put stents in to open up this large blocked vein in people that already have post-thrombotic syndrome, to what extent do we reduce their severity of their symptoms? To what extent are they more functional? Do they have better quality of life? And then also, how long do these stay open? And is that benefit preserved over several years? And then what's the safety side of the equation? It takes in a minimally invasive procedure to put them in. We anticipate that there will be some risks that go with that. And we'd like to understand, okay, just let's quantify that so that patients really understand when I make a decision, if I'm going to have a procedure like this, is this really likely to be the best thing for me? And am I comfortable doing that?
And do patients experience an immediate relief after this is done? Are there certain patients that are precluded, i.e., can you participate 6 months after you've had a DVT, 6 years, 16 years? Like, kind of what are the guidelines?
Sure. Yeah. So patients, to participate, they have to be adults or 18 or over, and they need to have had a blood clot more than 3 months previously. And they can, but the blood clot could have been 20 years ago. Really, there's no limitation on how long ago. And they have to have symptoms that are significant in their lives. So we don't really put people into the study that have very mild swelling but it's really people that really are having symptoms that really affect their lives in a substantial way. And that we demonstrate on imaging to have some blockage of their iliac vein.
Mm-hmm. Okay. Todd?
In terms of your other question, the response, we know that in many or most of the patients, we're able to using catheter-based techniques and imaging guidance, wiggle a little wire through the blockage. We don't get through all the time, but most of the time. And then we can get those stents in there. And when we're able to get them in there, what we've observed is that most patients have improvement over the next several weeks to months in terms of their symptoms. Yeah. And a lot of it depends, though, we don't totally understand why some people improve dramatically and some don't have as much improvement. And it probably has to do with the amount of damage that the veins have taken from the previous blood clot, and then other factors that we don't totally understand. But hopefully the study can give us more insight so that we're in a much better position than to give patients the right guidance going forward.
It's really interesting. I'm thinking, Todd, at some point we should take a trip to Washington U and actually see how Suresh does this, because I think that would be really fascinating for patients as well.
That would be fascinating. And, as far as the CTRACT study, Suresh, if people want to get in, you're still taking people who want to be enrolled in this, right? How can they do that? How many do you have currently enrolled? But more importantly, how can people get in touch with this program and actually get enrolled themselves?
Sure. So the study is being conducted in about 20 hospitals nationwide. We've got very good study teams of doctors and research staff at each of these sites. We have a website that you can see kind of the header behind me here, but it's a bloodclotstudy.wustl.edu. But if you just put in blood clot study into Google or CTRACT into Google, it will come up. That's probably the easiest way for a patient to find us. But the bottom line is that when you do that, if you indicate that you would like to be contacted, someone from the Central Coordinating Center team will contact you and get a little bit of information about you, just to make sure that it really makes sense to connect you up with a study team that's nearest to you, and then go from there, and then be evaluated by that team just to be sure that that you kind of fit properly. And in the course of that, you can hopefully learn a bit more about your condition, specifically. Right. And that's one of, I think, the great advantages here is that we've got a lot of teams of doctors that really pay attention to this condition and care about it.
Good. Thank you.
And how many patients overall were you looking for again?
Total 374. We've enrolled 148 so far.
Okay.
So the study is likely to be active for a good while longer.
Okay. And is there any effort to make sure that the study is actually diversified? Are you looking for a certain amount of men, certain amount of women, certain amount of Caucasians, certain amount of African Americans, et cetera? Because a lot of times studies aren't diversified enough. So just want to make sure that we're doing this.
Absolutely. It's a great point. And so far in the study, we really do have quite an excellent demographic mix and gender balance as well. That is something, this study is actually supported by the National Institutes of Health. And in addition to the fact that this is just a good, right thing to do, they monitor that as well. So we're really, paying attention. So really, people with the condition from really any walk of life are welcome, really.
Okay.
That's great. We love to hear that. So what we'd like to know is there a patient brochure that patients can download? I know you have your website behind you, but is there something that patients can download to read, to educate themselves? And if so, NBCA obviously would love to be able to have that on our website as well.
Absolutely.
So if there is material that you can, provide to us, please do. And then I'm assuming there is material that patients can download.
Absolutely. There is, on the website, and we can also provide you additional material as well. Yeah. And we have the brochures in English and in Spanish.
Oh, great.
So when are we going to receive the results? When is the CTRACT study going to end? And when will patients be able to follow along and check out the results of all that?
I think the final results will probably be a few years away from now. It's hard to know because it depends on how fast enrollment continues. And during the pandemic, it certainly slowed down, for lots of good reasons. But it's picking back up again, hopefully. And realistically, we do follow patients in the study for about 2 years. And so from the time the last patient's enrolled, unless something changes with the study, it'll be a couple of years after that. So we anticipate it'll be a few years away before we have final results. Yeah.
Okay.
But I do think we'd be very interested in being very active about getting the word out about those results and answering questions from the patient and family member community about them. So we're very open to that as well.
Yeah, I think that's probably where we should focus our efforts after the fact, once we have all the data available to share, because I think our community also would love to just hear more about PTS in general.
Sure.
Suresh, thank you so much for joining us today. I'm fascinated by this and would love to have you come back and actually do a demonstration without a patient, of course, in terms of what you're actually doing, because this is a really complicated space and you're one of the world leaders in it. And I think the patient community would really love to see, kind of how it all comes together on their behalf.
Sure.
So thank you
for today. Absolutely delighted to do so. And thanks very much. Really do appreciate this opportunity.
I echo everything Leslie just said. So thank you so much for joining us, Suresh.
Thanks so much. Yeah, take care.
All right. Bye-bye.